Thank you, Dr. Fernandez, for the invitation to come and speak to you all. Hi, everyone. My name is Clay Chung from LA Care Health Plan. Good to see a lot of representation from a different health plan here. Obviously, the LA Care people are sick and tired of hearing me speaking, so none of them is here today, except for the two of us. This is a great opportunity to come and share with you what we've been doing as it's related to the practice transformation grant that we got from CMS. So I'm going to get started, and Whitney will come and talk to you on the bulk of what we're doing with our participant physician group as well as physicians. Because this is a CME program, and it's very important for us. Thank you, Dr. Fernandez and HSAG for giving us an opportunity to collaborate with you in providing CME activities for the work that you do in educating the providers. So it's very important to us that you give us an evaluation and be brutally honest, seriously. And if there's any other topic that you'd like to see, let us know as well. We are an accredited CME provider as well as a CEU provider for nurses, licensed behavioral health specialists like psychologists, MFT, and FCSW. So we've been hitting a lot of conferences. If you'd like to be on our mailing list, just let me know. Send me an email and then I'll put you on our mailing list. We've actually just gotten recredited for 6 years. So we're very happy with that. As you probably not know, or do know that getting accredited for 6 years is a chore. So we'd be very proud of that piece. I'm going to take this time to give a plug to a conference. I know it was a last minute for most of you. We put together a conference tomorrow, and as it's related to the end-of-life options. As you know, it's a law that got into effect, affected June 9th, a couple weeks ago, and there's been a lot of confusions on what does that mean. And so we got a panel of a lawyer, actually a legal person from the California Medical Association. We got a clinical bioethicist, we have a psychiatrist, we have a physician who do in the front line, and then we also have another physician who will train folks on how to talk about this topic to your patients. And actually we're framing it as a continuum of care, where we will talk to you about the palliative care, which is a new benefit starting next year for California. And then we'll also be talking about hospice care and end up with the end-of-life options. I'm not going to say anymore. We have a flyer here, so we'll send it out. And if you're interested, please let us know. You can walk in tomorrow until we try to accommodate as many people as we can. There will be physicians, people on the behavioral health side, people on the legal side, lawyers, and also consumer advocate will be there. So it promised to be a very lively conversation tomorrow. And it will be at the Almanzor Court in Alhambra. If you are not familiar with that, it's a really nice place. This is absolutely free. And not only you get free CEU, CME, but you also will get a nice breakfast and a lunch as well. Food always do magic in getting people in, especially on a Saturday. So hopefully we'll see you there. It'll be 6 CMEs and 6 CEU credit. Okay. Since this is a CME event, we have to disclose that neither Whitney and I have any relevant financial relationship with commercial interests to disclose it. So the objective of this presentation is we want to identify the structure and core outcomes of our PTN initiative, and then we'll talk to you about 2 national learning collaboratives that LA Care have been participating in. The reason why these 2 collaboratives are very important to us is that it's actually tied into the integration of behavioral health and physical health. At minimum, looking at people with severe persistent mental illness, I'm sure all of you have encountered this population in your practice or in your health plan. So, in case you don't know, LA Care Health Plan is the largest public health plan in the nation. We now have crossed over 2 million lives. Now, some people might say, oh, yay, that's great. I see that as a sad thing. It means that a lot more people in LA County are poor than we thought. So, those of you who've heard me talk about this, I think the end goal for us would be able to help people to integrate into the community, get better jobs so they can no longer need Medi-Cal and be able to afford their own insurance. So that's my personal goal. The public plan for Medi-Cal 2 plan models and our sister plan or our cousin is Health Net, and a lot of Health Net folks in the room, and I know some of them here. We've been working very closely with Health Net in a lot of initiatives, specifically when it has to do with behavioral health, working with the local county department of mental health, as well as the services for children with autism. So we went from being cousins to being siblings in recent years. We designed to provide health coverage for the vulnerable population, and actually the other mission that we have is to support the safety net provider in Los Angeles County. Right, so at this time, I'm going to ask Whitney to come up and walk you through our LA PTN, and then we open up for question and answer briefly after her presentation, and then I'll come back and talk to you about the 2 learning collaboratives that we have.
Okay. Hi everyone, thanks for joining us today. So I'm going to walk through a handful of things that are all associated with the Transforming Clinical Practice Initiative. So in LA County, we're called the Los Angeles Practice Transformation Network. So that's what LAPTN stands for. And I'll go through a little bit of the background, what measures we're focusing on, what is practice transformation, what does that even mean, and we'll go through the tools that CMS is providing everyone in the U.S. to use and leverage in practice transformation. And then I'll briefly go through just some of the things we've already learned from our work to date, and just going through some of our next steps. So I'll start off first. There's a lot of acronyms that we use in this project. So I at least want to go through this because I might accidentally use the acronyms. I want everybody to be on the same page for some of these. So TCPI, Transforming Clinical Practice Initiative, we have LAPTN, SANS, which are Support and Alignment Network, and then we have a Twin QIO, which is actually HSHP here in LA County. And then we have a practice assessment tool, which is called a PAT, and our measures we're looking at, a lot of them are called CPLM measures. And then by the end of the day here, we'll have a better understanding of what these other terms are. So the phases of practice transformation, primary drivers, secondary drivers, and what change concepts really mean as far as which the practice assessment tool. So some background on LAPTN. Like I said, it's this part of the Transforming Clinical Practice Initiative. It's a CMMI program, and the goal of it is to work with 140,000 clinicians in the U.S. We are one of 29 other practice transformation networks in the U.S., and we're pretty unique in that we're local. Most of the other 28 PTNs are statewide or even multi-state groups of people working to transform practice. And so for LA County specifically, we're going to be working with 3,100 clinicians in LA County, and the 2 main things CMS wants to see by the end of our 4 years working with practices is that we transform them, and then that we also improve clinical outcome measures. And for us, our specific focus is on diabetes and depression. And so I'll go in through the course of this presentation to what is practice transformation, what are our outcomes that we're looking at. We're also utilizing, just to give you an idea of our structure, we are using what we're calling network partner model. So how we recruited 3,100 clinicians is through our network partners. And so these are our 5 network partners. We have Citrus Valley Independent Physicians, which is a very small IPA. Then we have Community Clinic Association of LA County, about 26 practices. Agencies are going to be working with us there, which is around 700 or so clinicians. We're also working with Glendale Adventist, LA County Department of Health Services, so DHS, and then the Department of Mental Health, DMH. And we have a small group in the direct network where we're actually going to be managing them, which is Dean Hirsch. So we have a good mix of both primary care and behavioral health practitioners represented in this 3,100 clinicians. So just to give you a broad overview of what is the program design, we really want to help the practices transform in what's going to be meaningful for them. So we want it to be tailored to their unique needs. We're going to be putting together lists of interventions that each of our network partners has a project manager that will be managing these interventions. And the goal is that the intervention would either improve one of the clinical outcome measures or improve on efforts of practice transformation. And throughout this whole process, we'll be using continuous improvement, our own little mini PDSA cycles throughout the whole thing, so that we can keep improving and make this meaningful for our practitioners. And what's unique about us is that we are going to be having on the ground what we call practice coaches that are going to be working directly with practices. So our ratio of how we finance this is about one coach per 100 clinicians. So with that ratio, people like the Department of Health Services will get around 8 to 10 practice coaches to be out there working with their facilities. Department of Mental Health will have about the same. So these people will get to know our practices. We're working with coach vendors. So people that our department, Health IT, has been working with for quite a long time to implement EHRs in LA County, so they've been on the ground for a long time, a lot of these people. So I guess I would ask if there's any questions that come up, I'm happy to answer them as we go through. So, yes.
What do you think about the ratio of one coach and 100 coaches?
Yeah, so we have, a certain amount of money. We have about $15 million over 4 years, and we're funneling a little over 80% of it down to pay for these coaches. So we've tried to get as many coaches on the ground as possible, and I think that ratio works for larger organizations, but when we look at some of our more IPA-based structures, it's going to be much more difficult, and we've seen that. Maintaining our enrollment, getting people to sign up, staying with us along the way, because everybody is quite independent in those structures, whereas a Department of Mental Health or a health services, they've integrated into their overall strategy that we're going to be working with practices, so there's a little bit easier. There's still more layers than working directly with the practice, but
So unless you deal with solo practitioner, the participant in our pilot projects are mainly group clinics, etc. And we do know that at the individual doc level, there's no way you're going to work with the doc. The doc just doesn't have any time to work with you in workflow and what have you. We realize that usually it is the manager of the clinic or the nurses who are managing the clinic is the one who's critical in implementing practice changes, right? So this is all, we see this as a workflow. So the coaches will work more with the clinic managers and to assist them in how to provide a workflow that makes sense for them and get them ready for the new payment in about 4 or 5 years. And it also tied into the fact that we picked depression and diabetes because those are the two most common conditions that any PCP would see. And since we're talking very much about integrations, and you've all probably known that there's many model integrations, and people can tell you about, well, which one's better than which one in terms of theory, in terms of workflow, but actually, we still struggle with carrying out integration because of the financing piece. Especially in California, when you talk about Medi-Cal the financing piece is splitting for mental health, for substance use disorder, and then for physical health care. So you can have all the integration model you want, but if the finance piece is not together, it's very difficult for them to practice that. And that's why we're using, and we purposely pick depression and diabetes, and we purposely targeting Department of Mental Health and clinics that provide mental health services in the community, because we know in order for us to come to a whole person care, lack of a better word, you really need to integrate that level of services and get all the providers to come together. And we will be purposely assigning coach to clinics that work together, which I'm going to talk about in one of our learning collaborative, because the coach that go out and change, help practice change, need to know would the flow from a mental health provider make sense for a physical health provider? Could it be established two different flows? In the end, you still won't be able to communicate or get together and concentrate on the whole person care. So I know it's a long way of answering your question, but I'm so glad you asked that question.
I know you think about all of those pieces.
Thank you, Dr. Lay.
So this is our design and,
Sorry, I was trying to.
Yeah, no
I'm just going to tell you that we've done some work with HRSA on a collaborative where we had similar ratios as you had initially, but what happens is when you work with these teams to enable them to be successful, you start to grow coaches. So it's an all teach all their kind of collaborative mindset.
exactly. Yeah, so
Yes.
part of our structure is that we will have our coaches all be part of something called a learning collaborative, and that's going to be a way for everybody who's out in the field to come together, where we will learn from what other practices are doing. We can see what's working, what's not working, and which settings is it working, and which settings is it not, and there can be real collaborative and quick learning from everybody coming together. And in those learning collaboratives will be for our coaches and for all of our project managers, but we also have a layer to our learning collaborative that is free CMEs and CEUs that will all be linked to these ideas of what practice transformation is.
So we'd love for this to be interactive, so please, you're not handing us anything. Please ask questions. The piece that is very important is that, at least in our approach, it's not that we're bringing down best practices to the practice, but rather create a forum for all the practices to share their own best practices, right? And then help them elevate, if they have practice, and everybody agree that that's the best practice, help them elevate and bring it up and send it up to CMS and help us spread. Because technically speaking, we're not the expert. It is the practice out there seeing the patient that is the expert.
And this is Mary. I just want to check and see if you can hear. Good.
On your mic.
I can be Oprah too, don't worry. You have a question? Not that I'm as pretty as she is, but.
So I have two questions. And one of them is there any financial incentives for best practices to be carried out? And secondly, I used to work for kind of in this very large county setting. And what I noticed is that there is a directive that comes down, some sort of project that needs, execution. And you tell them, the program managers, it varies by how respected that individual program manager is. So the success and the failure of the actual project becomes very dependent on that particular program manager for the clinic. So for instance, if the program manager happens to be a nurse practitioner, that's not respected, and yet she has to teach the entire clinic how to move in a certain direction, and all of the prescribers who are MDs may or may not respect the program manager, then that clinic would basically, it's a high percentage of probability of failure. So, if you can just talk about this.
So I'll answer the second piece first. What you're talking about is the buy-in from the whole system. So we got the buy-in from top down to bottom. That's the most important piece, right? And then the other piece is selections of the program manager, that you pointed out is very important. As far as I know, the program manager for most of our participants are actually very well respected folks, came with a lot of years of experience, and we participate with them in the selection process. So yes, this is very crucial. But again, for the purpose of this project, yes, the clinician, the individual clinician and the patient participate, but we want them to realize that it is the people in the back office, people who do the billing, people who do the communication, that's the driver of this process, right? Because we want to make sure that the clinician do clinical work and not caught up in a whole lot of clinic politics, lack of better word, because you see that everywhere. So you're right, you need to have a top-down buy-in. We do have entities that dropped out because they didn't have the buy-in for the whole system. But the good thing is we have a wait list of people who want to join us as well. So we're good with that. So the first piece that you asked is very, very important. And I think Rudy will be answering your question if we give her time to talk about it. Any other questions? Yes, ma'am. Coming to you.
I was just wondering, in the community health settings like Didi Hirsch, et cetera, will there be medical practitioners embedded in the clinics where there's the mental health perspective, and vice versa? Will there be psychiatrists or behavioral people in the medical?
So I think Didi Hirsch currently is not providing primary care, right? Yeah. But because they are contract with DMH and they are working with a community clinic close by that is part of the community clinic of Los Angeles, and I think they also participating.
Yeah,
So that's how we work. So we will have the coach that would work very closely with for Didi Hirsch, work very closely with the community clinic that they refer people over for physical health care. So they need to talk and figure out whatever workflow that they change in their practice has to make sense. And we do that on purpose. Good example is one of our learning collaboratives where Designer Treatment Center is a primary care and SP provider who has an MOU with one of the county department of mental health clinic where they send in their primary care team to work with that clinic. So we are providing a coach that will change the workflow for both that specific DMH clinic and Designer Treatment Center in order for it to make sense and for them to drive towards total person care. I mean, my dream, actually, all the health plan now, I think our behavioral health side is carved out from the physical health care entity. I'm looking at my friend Natalie. Truly, for integration to happen is that a physician group, let's say Dr. Tipton's group, should have all the funding to provide all the care, and it will be up to you to ensure that you have behavioral health staff provide the care. So that's what we're looking into in the long run, hopefully soon.
To that note, CAPG, this was brought up, some entities, because mental health is carved out, they've got, and they want to provide total person care, they've gotten very smart. So what they've done is that they've hired mental health providers, and then they have them bill the whatever TPA, and then the record becomes integrated because it's from the same place.
And we do that for many of our community clinics here that provide physical health care. We encourage them to hire mental health specialists and have them in one place. And they actually, the mental health providers, contract with our carved out, within the health plan carved out mental health vendor. But the goal should be, we should be able to capitate the entire thing to you all. So you can do the whole person care and take the risk, because that makes sense. Currently we can, because you probably know that the utilizations or the penetration rate for the mild and moderate populations is quite low. It's consistent in all health plans. Now, is that because of our carved out behavioral health model, or is it because stigma, or is it people don't know how to refer folks from mental health treatment, or is there some sort of barriers? We're looking into it together.
There's a question.
Just
Yes.
a quick question. They didn't address this at CAPG. Why was it initially?
Why was it initially,
Of course.
why was it initially set that way where it was carved out? Because we have to find out why initially that was done so that we can reverse it.
Yeah, that is a loaded question with a lot of politics involved.
I got
At
it
the
now.
federal government level and at the state level. So, in case you don't know, for Medi-Cal, the carve-out system is mental health piece is to the specialty mental health. So before January 1st, 2014, if you have Medi-Cal, your option for mental health services is either the county, your local county Department of Mental Health, or your PCP. Now, the county Department of Mental Health has a level of medical necessity that you have to meet in order for you to receive services as county mental health. So it left a whole slew of people in between that weren't able to get any services. So with the expansion of Medi-Cal, the state implemented the mild and the moderate level of care and put it in the health plan. I had this feeling about that because prior to January 2014, I was working on the county mental health side. And to me, that is yet another carve-out system, right? Because what you're saying is that if you have mental health condition, when you are, so if you have a mental health condition, and when you are mild and moderate, you go to the health plan provider for mental health services. The minute you hit severe, then you go to the county. Now, what happens when I stabilize?
Things down. And then sort of to speak to one of the ladies' points over here is that when we worked with our network partners, for example, Department of Health Services, we really want to integrate into what are their strategic goals already. For example, the DISRIP program, so the waiver where Medi-Cal will get significantly more payout if they meet certain quality measures. So we've been able to get the buy-in, bring it all the way up very high within that organization. So we have a lot of buy-in from above, and then we have program managers that have been in the organization already. So they're not all just new people coming in. Okay? So I guess we'll briefly go over what measures we're looking at here. So when we think about what our practices are going to be measuring, we have it segmented. So we have primary care practices and other specialties focusing on these 4 CQMs, which are diabetes, poor control, medical attention for nephropathy, BMI screening, and if it's out of range, then a follow-up plan, and then clinical screening for depression and a follow-up plan. And so those measures are all eCQM measures, so they should be able, they're part of meaningful use state. We'll be able to pull them directly from the EHRs, depending on the network partner, how they're structured. We're working a little differently because sometimes we have a whole IT department or data quality department that we're working with. Other times it's us going into the practice, printing out meaningful use reports. But we're going to be rolling all of that up. So at the NPI level, we don't collect any patient level information, just numerator and denominators for these measures. And then thinking specifically about behavioral health focused quality measures, we have worked with Department of Mental Health to sort of adjust what our measures are going to look like for behavioral health practices because, doing a screening for depression and not monitoring that doesn't really make sense since they're getting the people that already have depression. But we've also wanted to keep some of the chronic disease measures and things in here too because we want to think about the whole person. And so we don't want to forget about A1C control. Especially for patients that have schizophrenia, might be taking medications that increase their risk for insulin resistance and diabetes. Also, a lot of medications can cause weight gain, so we want to keep monitoring the BMI. We're also thinking about how do we prove that what we're doing is working, and a lot of times that there's no data to really show it, and something that's going to be an initiative within the Department of Mental Health is to better leverage the PHQ-9 for monitoring of depression symptoms. So every time you see a patient, redo that PHQ-9, see where they're scoring. Are they improving? Are they staying the same? Are they getting worse? You need to adjust your care plan. And then we also are thinking, so if there's a follow-up for depression, one of those follow-ups includes a suicide risk assessment. And so we wanted to have both child and adult for that. And then specifically this idea of follow-up after hospitalization for mental illness, that gets back to all these silos that are happening when somebody is admitted for psychiatric, to a psychiatric hospital. It's really hard to get that information shared to the right people, to their primary care doctor, to the Department of Mental Health to actually complete the follow-up. So each one of these measures, we actually have different initiatives or interventions that are going to be put into place. And for example, with follow-up after hospitalization, we're going to be working on connecting with some of those top volume psychiatric hospitals so that information can be shared real time into the Department of Mental Health. There can be workflow adjustments and processes that will improve the ability to follow up with these patients so that they get in really quickly after their discharge. Yes.
The end of this presentation. Whitney gonna tell me that she doesn't want to work with me anymore. So in case you don't know, from Medi-Cal side, even if a member is sitting on the moderate, the health plan responsibility, the minute they end up in a psychiatric hospital, it becomes the county Department of Mental Health responsibility to pay for that inpatient services. And Department of Mental Health anywhere in this state does not do concurrent review. They do retrospective review. So you could see they do not know in real time whether or not a patient is in the hospital or not. So we need to work with them to help them creating a platform where they get real information in real time and share with us, and that way we can plan for the transition of care when the patient gets admitted. So that's why DMH is very excited to work with us. Okay? So that piece is very important because on our HEDIS score and also in our STAR measures, there are a couple of measures related to follow-up hospitalization that currently most health plans said, oh, we're not responsible for it because we don't have that responsibility. Technically speaking, we should have that responsibility in working closer with our partner in the DMH side.
Yeah, thanks for putting that into perspective because, like I said, there's so many layers in how things get especially during transitions in care. So we also have some utilization measures, and just because of how things are structured, utilization measures are much harder to get from clinicians, especially if they're not even enrolled in our health plan. So thinking about these 3,100 clinicians, a lot of them aren't even LA Care providers. We are not taking any patient level data, so our way of doing our utilization measures is that we're going to be using LA Care data, but then we can extrapolate that. So we're going to be looking at our data on all-cause admissions for patients with diabetes as well as depression, and then looking at different ways of monitoring unnecessary testing, and we have our goal of cost savings related to decrease hospitalization and readmissions. Okay, so we'll go on here. So we have this idea of what is practice transformation. So I think, we'll have this picture of data. We're going to be using, we have a clinical data repository where we'll be able to upload all the CSV and Excel files of data that's outputted from these EHRs and then roll it up from NPI level to practice level to agency or facility level to their network partner level and then up to our LAPTN level. And that's something that we'll be able to monitor over the course of the next 4 years, where we'll be getting these eCQM data monthly is our goal. And so right now we're sort of working with each of our partners to build things so this can be more regular use of real-time data. And so we have this facet of the clinical quality measures. The other idea is what is practice transformation? And that is something that's just as heavily weighted as improving these measures is how are we going to transform these practices? So I would ask if we could hand out, I don't think I have enough for everybody, so, but we'll be going through as sort of a little idea, what is a practice assessment and what is CMS wanting to measure as far as practice transformation. So there's a CMS tool that is going to be handed out, and we'll go into more detail in a little bit on that. But in the big picture of things, the goals of CMS are that a practice can start setting aims, developing basic capabilities, get up to being able to generate data and reports to have improvement, get up to achieving aims on the triple aim, lower cost, better care, better health, eventually get up to benchmark status where they are able to get the most payout for the quality of the work that they're doing. And the main end goal of all of this is that we want practices to be able to thrive via pay-for-value approaches. So there's a lot of changes with MACRA and MIPS and different waivers that are coming through. And so how does the practice survive in this environment? And ideally is if we can bring them through these phases of transformation, then we will be able to have them be successful.
Brittany, can you just explain what the tool is?
Yes, I'll be going into that. So I just wanted to pass it out now, but we will go into detail on that tool. So just thinking of how we do this is that we're gathering each practice, small and large. We're bringing in the people that are their decision makers. So we've completed about 70 assessments at this point of about 100 practices that we'll be working with. And some of those are just solo practitioners up to some of these larger organizations with 100 plus clinicians under them. But really it's been an iterative process. I've been working with Emily here very closely to do this, and we're going into practices, meeting with their CMOs, their COs, their CFOs, their heads of nursing, quality, social workers sometimes are at the table, but we really want to get different perspectives all in the room so that we can get a big picture of how is this practice moving? Are they ready for change? And so what we've done is use this tool, and we go through the scoring, and at this point we're looking at our analysis. We're finishing up some of our last practices, and based on that is where we will start saying, here's a gap, how are we going to close this gap? And then that's where the interventions come into play. And this tool, which I just passed out, I know I said the data will be monthly, the practice assessment will be every 6 months to see where are we going, have we moved. So what is this practice assessment tool? There's 2 main tools as far as this goes, and one of them is this thing called a change package, and it's a 32-page document. The Lewin Group, this consulting firm, has worked with CMS for many, many years, going out to all the high-performing practices in the U.S. and figuring out what is working for you, how are you doing this, show us how do you prove that this is happening. And so once they got all this input out of years of this consulting with different practices, they've combined it into this it's a really great tool because it gives you a framework for what this operational change is going to look like. And this change package, once they rolled it up, they have a little map here where we have our 3 primary drivers. So the main things that CMS is looking for is this idea of patient and family-centered care, continuous data-driven quality improvement, and sustainable business operations. And you can see that the bulk of the questions on the tool I just handed out are actually 17 questions. They're all around this patient and family-centered care design. So that includes, I don't have a lot of those because I didn't want to hurt too many trees there. But I have that tool too, so you guys can take a look at the change package. And then the practice assessment sort of maps to very specific parts of the change package. And so when we think about it, these 3 primary drivers, then there's 15 secondary drivers. And each one of those 15 drivers is assessed on this practice assessment. And so our first version of the practice assessment was not mapped to this at all. It was over 40 questions, not very clear. Our second version, which you're looking at today, is much more clearly mapped to these ideas of change. So we have the 15 secondary drivers, and then each one of those in the change package get broken down into something called a change concept, and then there's example tactics of how you would achieve these things. So I'd like to go through this tool. I'm wondering, can everybody see a paper version? I'll also pull it up on here. But I do want to just go through what the change package looks like, what the practice assessment looks like, because this is something, even though we're using it in Transforming Clinical Practice, TCPI, CMMI, big grant, this is something that any organization could use right now and leverage it for themselves. So maybe you don't have all this practice coaching or learning collaboratives and things like that, but it's something, you know, if you're a self-starter, you could easily start using it as a